I'm Dr. Henry Black from the New York University School of Medicine and president of the American Society of Hypertension. Today I want to talk about something that our Food and Drug Administration recently did. In fact, early in August, they approved two compounds, two fixed-dose combinations for initial therapy for hypertension. They had done one earlier in the summer and another about a year ago. Now this is very important for a couple of reasons. First-line therapy is something that doctors look at. It doesn't matter so much what's first and second-line therapy, but there's a principle that where you begin treatment for high blood pressure has a lot to do with how you will succeed. Doctors for a long time have started with a single drug, and then if blood pressure wasn't where we wanted it, they would titrate the dose up or add a second drug. And in 2003, the 7th Joint National Committee recommended that for anybody who had stage 2 hypertension, that is, their systolic blood pressure was equal to or more than 160, and or their diastolic pressure was equal to or more than 100, that you should start two drugs, one of which should be a thiazide diuretic. Now this was not in conjunction with the Food and Drug Administration's recommendations for initial therapy, but it's become clear that as we realize how important it is not only to get blood pressure to goal, but to get it to goal promptly, that starting two drugs in certain individuals was a wise thing to do. Much of this came from our appreciation of the Oxford study on risk of hypertension with increasing blood pressures and increasing age, and had to do with our appreciation as well that a single drug, whichever you pick, is likely to get you on average about 10/5 reduction in blood pressure, which isn't going to get certain people to goal. Now that was also compounded, if you will, by our understanding from the ALLHAT study, from the ASCOT study, and recently from the VALUE study as well, that the first month to 6 months of treatment really predicted how someone was going to do with respect to events. ALLHAT showed that in the first 3 to 6 months that African Americans with chlorthalidone therapy had a better drop in blood pressure than they had with either amlodipine or with lisinopril. And this was the subset of our ALLHAT population that had a reduction in strokes with chlorthalidone. In the VALUE study, the therapy in the first month, and especially in the 6 months, regardless of whether you got amlodipine or valsartan, also predicted outcomes. So this reinforced the recommendation that prompt therapy was a good idea, and that you weren't going to necessarily get there with a single agent. So I'm very pleased now that the Food and Drug Administration has gone along with our Joint National Committee guidelines and with physician practice, endorsing the practice of starting with two drugs. I think this is going to be an important thing, and I think getting blood pressure in high-risk individuals, and everybody with stage 2 hypertension for the most part is a high-risk individual, will go a long way toward us reducing the cardiovascular epidemic. I'm Dr. Henry Black from New York University and president of the American Society of Hypertension. Thank you very much.